We're grateful to have you here. My name is Sandra Kwati-Owusu. I am a pediatrician and pediatric pulmonologist, associate professor at the School of Medical Sciences, Department of Child Health, Kwame Nkrumah University of Science and Technology. I'm excited about this afternoon's topic that's very dear to my heart. We'll be discussing when the lungs meet sickle cell and what every clinician should know. I beg your pardon. We have exciting talks coming up, and we believe that at the end of the presentation, we would have something to take away with us. I would encourage all of us, please keep your microphones on mute and your cameras also off so that we can have a good bandwidth. So to start the presentation, we have two exciting talks. The first one will be delivered by Dr. Joanita Nampijayouted. Please forgive me if I pronounced it wrongly. Joanita is a pediatrician at the Uganda Martyrs Hospital in Lubaga. Joanita, thank you for agreeing to give this talk. I'll now hand over to you to project your slides and present. At the end of the presentations, we'll take questions. I will come back again and give directions. But please, you can also put your questions in the Q&A box, and I would help address them after the two presentations by reading it out. Thank you very much. Joanita, I'll hand over to you.
Good afternoon, everyone joining from wherever you are. I'm glad to be here. My name is Joanita Nampijayouted, it right? I am going to share my presentation. Are you able to see my presentation?
I think the slide is coming up. Yes, we can see it.
I'm going to put it.
Yes, it's in
I'll
slide.
go straight to the case. So this is a case of a female 16-year-old Muganda that is attending senior secondary school from 3, a Catholic from Kawempe, who was admitted at our hospital on the 3rd of August 2025 and was later discharged 5 days on the 8th of August. I also put date of spirometry was done on the 15th of August. So the presenting complaints were recurrent history of cough for more than 2 weeks, and also presented with pain in the lower limbs for 3 days. So she's a patient of sickle cell anemia. She was diagnosed at the age of 6 years and had been attending the sickle cell clinic since that time. She's currently on a dose of 25 milligrams per kg under the guidance of a hemato-oncologist at the Mulago Hospital, with a daily folic acid intake, monthly Fancida, and daily maltoids. She comes in for her routine checkups in the clinic, but at this time of the visit, she was unwell. She presented with a dry, irritating cough. That was progressive. Okay, I think I don't know if I stopped sharing at some point. I can't see. Okay, that was irritating. Progressive for 2 weeks, associated with retrosternal chest pain and chest tightness, with progressive DIB and shortness of breath. The cough was unresponsive to ordinary unknown antibiotics that she was taking. There was no history of associated fevers at the time of admission. She reported no history of proximal nocturnal dyspnea, orthopnea, or easy fatigability. This kind of chest pain was a common thing to her and sometimes would be associated with chest heaviness. And these events were mostly during the cold weather, whenever she caught a flu or a cough, or during strenuous activities. To her, these events were always managed as acute chest crisis with oxygen and antibiotics, and in the past 1 to 2 years, they had been quite recurrent. She reported that in about a period of, she had had about 2 to 4 episodes in a period of a month. So these episodes were mainly not associated with fevers. The review of other systems were unremarkable. Her past medical history and surgical history, like I said, she's a patient with sickle cell anemia. She's attending clinic regularly and she's on her meds. She has very good adherence. She had had a number of admissions, especially in the past 1 to 2 years, due to similar presentations, and there were no reported other chronic illnesses or history of allergies. She had had 3 times of a blood transfusion in her life, no major history of trauma. However, she had a vascular necrosis of the head of femur, and she was currently being prepared for left hip replacement. She was ambulating on a supporting stick. Social history, she only stays with her father and stepmother. Parents separated after her diagnosis. She has 2 other siblings who are sickle cell carriers, but otherwise well. No known chronic familial illnesses like asthma, diabetes, atopy, except hypertension that is known in the paternal side. She's currently attending secondary school in senior 3 and doing well in class. So at the time of her examination, we found that she was in a fair condition. She was obviously breathing away with a temperature of 36.6 degrees, mild pallor, no jaundice, with dry mucous membranes, and no central or peripheral cyanosis, but she was able to prefer a particular sitting position, which was forward. She was fully awake, conscious, well-oriented in time and place, with no obvious neurological deficits. Her respiratory system, obviously, she wasn't breathing away in distress, with a rate of 25 breaths per minute, with subcostal recession, good air entry bilaterally, and oxygen on room air was 90%. And on nasal prongs, she was doing at 94%. Heart sounds were normal and no added sounds. Abdomen was normal. So at that point, we thought she was a patient of sickle cell anemia with acute chest syndrome, pericardial septicemia, and painful crisis. So the investigations done, the CBC, as you can see, was quite unremarkable with a good HB of 9.8 for her condition. Her CRP was 12.5 grams, almost normal. Chest X-ray was unremarkable. Malaria was negative. The procalcitonin levels were 5, also normal. And LFTs and RFTs were normal. Fat was negative. So the management plan was Isin 500 milligrams daily for the time of admission, oral morphine, oral paracetamol, urea as usual, and folic acid. Zinc was done daily with IV fluids for support and reassuring our parents. So in the next 3 days, she was better, was ambulating on her stick as usual with less pain. However, she still had this cough that was persistent and a retrosternal chest pain. At that time, she was markedly better and was discharged on the 5th day of admission with a follow-up plan of a cardiac echo, spirometry, to complete her 5 days of azithromycin and cefixime, and also be reviewed in the clinic as usual. So on her review, we noted that the cardiac echo showed mild hypertension, mild pulmonary hypertension. The spirometry done, if you could look at it at once, it would give you normal findings. However, she had a pipe problem. Her FVC, once subjected to bronchodilator, significantly improved to almost 9%. This is the interpretation of the spirometry findings. So her bronchodilator responsive test at her FEV1 and FEV one before. If you looked at it, I could go back. The FEV1 post was 2.51 and the FEV1 pre was 2.26, and that difference divided by the FEV predicted times 100% gave us 9.9, which is almost approximately 10%. This accounted for positive bronchodilator responsive test and was a complete one. So the follow-up was begun on formonide at that time in August with a spacer and mask, because we noticed that she was not using her inhaler well. During that 4 months period, she was progressively coming to the clinic. She had no admissions and her chest pain and cough had disappeared. By April, she had been put off inhalers April this year. And when we reached her out recently, she noted that she was fine and doing well at school. She's in a boarding school. So her next review is next month in 2026. We shall be hearing from her, but so far so good. She's stable. Thank you very much.
Thank you. Thank you, Joanita, for sharing a very interesting case with us. We are so grateful. We'll move on to the second presentation, which is going to be done by Dr. Deogratias Monube. Dr. Monube is a consultant pediatrician and also honorary lecturer at the Makerere University. He has subspecialty training in pediatric hem-oncology. He's head of pediatric oncology at the Mulago Hospital in Kampala. Mulago Hospital is a major referral center for children with sickle cell disease. Dr. Monube is also a member of the Sickle Cell Pan-African Consortium, founding member of the Sickle Cell Disease Ontology Working Group for Africa, which was initiated by the Ministry of Health. We are very happy to have you present to us this afternoon, Dr. Monube. I'll hand over to you. Thank you.
Thank you, Professor Owusu. I hope you can hear me and you can see my slides.
100%.
Okay, so thank you. So we shall have a discussion around sickle cell disease and asthma. That will be the outline of my talk. We will try and look at just our key definitions to put ourselves together and what we're going to discuss. And we'll look specifically at how asthma and sickle cell disease relate, and we'll see why it's important. And we'll go into some few guidelines when it comes to the management of asthma, and then we shall conclude. So by the end of this session, I hope that participants will be able to at least remind themselves about the definitions of both asthma and sickle cell disease. We'll look specifically at some of the amino acids that help relate asthma with sickle cell disease and a few theories around the interactions, and then we'll look at the treatment. So by way of introduction, this is a simple definition from the GINA report that asthma is a heterogeneous disease usually characterized by chronic airway inflammation. And when sickle cell disease is an autosomal inherited recessive disorder, which leads to production of hemoglobin S. You will note that on both communicable diseases or considered as non-communicable diseases. There is a cartoon which I'm displaying here, which looks at the relationship between sickle cell disease and asthma. In sickle cell disease, you have the hallmark of hemolysis, while in asthma, you have inflammation as a result of eosinophils increases. And when you look specifically at sickle cell disease, as you have the breakdown of the red blood cells, there is the release of nitric oxide, which then is a potent vasodilator. And as a result of this release and the spread of the nitric oxide, you find that you are unable to have efficient vasodilatation. Now, at the same time, arginine or L-arginine is one of the amino acids that is responsible for the uptake of nitric oxide synthase. And when it is reduced, it leads to a reduction in the nitric oxide and thereafter leads to a reduction in the L-arginine within the body. This simple disorder, which is being described in sickle cell disease, is actually also replicated in asthma. And in asthma, as a result of the inflammation or the airway hyperresponsiveness, the eosinophil secretions and inflammations lead to a similar outcome. As you can see in this cartoon, in the lower part is the intracellular pathway, and then the upper part is the extracellular pathway. So in sickle cell disease and asthma, the pathways may differ because one is due to hemolysis, another is due to key inflammation through the breakdown of the cells here. But in the intracellular pathways, the outcomes are quite similar. There is the absorption of the nitric oxide synthase, there is a reduction in the L-arginine, and then that leads to deficiency of the nitric oxide. These two aspects that I'm describing are similar features in sickle cell disease and in asthma. And as a result of that, you find that a child who has sickle cell disease may have specific symptoms which are related to asthma and may be related to other disorders. Now, why is this important? Asthma in sickle cell disease is associated with an increased risk of a complication called acute chest syndrome. Acute chest syndrome, as you would be aware, is a syndrome which is characterized by fever, increased respiratory effort, chest pain, hypoxia, and more importantly, when making a diagnosis, a new infiltrate on a chest radiograph. A child or an adult who has sickle cell disease and has symptoms that are related or which are similar to asthma will have an increased risk of acute chest syndrome. Now, important to note also is that the painful episode which is described in these children or adults who have acute chest syndrome can also be a trigger for asthma. And the relationship, as I described, is really as a result of the reduction in the nitric oxide, which leads to reduction in the L-arginine as an amino acid. And then that leads to hyperresponsiveness, and it also leads to further hemolysis. So as you think through the asthma that we're describing in sickle cell disease, it can be a direct trigger for the number of cases of acute chest syndrome that we see. And more importantly, a child or an adult who comes in with signs and symptoms of acute chest syndrome may have worsening of their asthma episode. Thirdly, there is some evidence that supports asthma and sickle cell as possible comorbid diseases, and I'll show you in the subsequent slides. But more importantly, it may be individual disease entities which have been described by previous researchers. Another important thing that we need to note is a family history of asthma in a child with or an adult with sickle cell disease is actually associated with an increased risk of acute chest syndrome. And also, in the event that they have an asthmatic attack with pain, the number of acute chest syndrome episodes tend to increase. In this graph that I'm describing, it looks at the incidence of asthma when it comes to acute chest syndrome and the incidence of pain when it comes to asthma. This study was done several years ago in the US, which looked at a cohort of about 300 children who were followed up for over 11 years, and the overall incidence of asthma in this population was close to about 17%. Important to note that this incidence of asthma is quite high when you look at the incidence of asthma in, for example, Uganda, where recently studies that have looked at asthma in our population is as low as 5% in our children with sickle cell disease. But more importantly, what I want to describe here, if I can just use a pointer. Okay. Sorry, go back. So if you can see my arrow, the lines in the upper part of this graph show you the number of acute chest syndrome episodes with children with sickle cell disease who have asthma, and the dotted line below it are the incidence of acute chest syndrome when this child is not diagnosed with asthma. So there is a clear difference between a child with sickle cell disease who has asthma and the incidence of acute chest syndrome, and one who doesn't have asthma and the incidence of acute chest syndrome. Subsequently, when you look at the events of pain and asthma versus pain without asthma, the number of painful events are higher when you have asthma compared to the number of painful events when you don't have asthma. And this is an important correlation that we need to think about when managing children who have sickle cell disease and present with asthma-like syndromes and those without asthma-like syndromes. There are some possible theories that have come about. Number one is asthma and sickle cell disease are two independent disorders, whereby you have sickle cell disease and you can be at risk of having asthma. Maybe having a family history of asthma, a positive family history of atopy, history or previous history of wheezing. So you would expose yourself to having asthma as an individual independent of sickle cell disease. The second one is that asthma and sickle cell disease can occur at an interface whereby someone who has sickle cell disease may have asthma-like syndromes and can progress to get acute chest syndrome as a result of these asthma-like syndromes. And the third possibility is that you have sickle cell disease and asthma. And in such a case, you would have a clear history of atopy, clear history of wheezing, and also a positive family history of asthma for you to have sickle cell disease and asthma. It's also important to note that as you look at these two conditions, there may be some features that are able to differentiate them. Number one, when you think of asthma and fever, fever is a rare occurrence when it comes to an acute exacerbation of asthma. When in acute chest syndrome, you will have episodes of fever. With asthma, you will have commonly the occurrence of wheezing, and in acute chest syndrome, it may occur in some cases, but not all the time. And in asthma, you may have mild to moderate hypoxia, while in acute chest syndrome, you have often severe hypoxia. Another important aspect that is good for us to know as clinicians, and this is really based on many studies, is the role of nitric oxide in sickle cell disease and asthma. Nitric oxide is a potent vasodilator, and when it is reduced in sickle cell disease, there is vasoconstriction, and this vasoconstriction is also prominent in children with sickle cell disease who have asthma. Asthma, as you may know, or has been shown in the previous graph, can increase the risk of complications of sickle cell disease. One, recurrent painful events. Two, acute chest syndrome. And I'll show you a graph depicting a long-term follow-up of children who have sickle cell disease and asthma, and then mortality associated with asthma. So this Kaplan-Meier graph shows you a long-term follow-up of children and adults over 40 to 50 years, and following them up with those who have no asthma and those who have asthma. On average, the life expectancy in Africa, and I'll say in North America and even in Europe, can be as high as 50 to 70 years for people with sickle cell disease, slightly lower in Uganda, between 30 to 40. But you can see here in this Kaplan-Meier graph, those who have asthma, as you go over the years, you find that the survival goes much lower compared to those who have no asthma. And this actually was quite significant. And it basically said that if you had sickle cell disease and asthma, you actually had a 6-time more likely event to die due to sickle cell disease and asthma compared to when you did not have sickle cell disease and you did not have asthma. So asthma as a comorbid disorder actually increases the risk of death in people with sickle cell disease over their lifespan. So as we go specifically to treatment, and I picked up this treatment guidelines from the NIH asthma guidelines, and I'll try to highlight a few important things that we need to know when it comes to treating asthma and sickle cell disease. Most importantly is the use of inhaled bronchodilators, especially when the children or adults with sickle cell disease come in with respiratory symptoms. There's a key role for corticosteroids when it comes to having asthma and asthma-like symptoms. It should be noted also that the role of corticosteroids, if you have sickle cell disease and acute chest without respiratory symptoms that are suggestive of asthma, there may be minimum role of your corticosteroids. The use of oral prednisolone is very important as an initial treatment to try and moderate the respiratory symptoms in people with sickle cell disease. It's also important to note that when you follow up children and adults with sickle cell disease, you tend to increase the number of days of steroids compared to our usual 3 to 5 days. You would actually want to give your steroids over a longer period of time as you taper them over 2 weeks. Case reports have shown that if you interrupt your steroid use over a shorter period of time, there has been reoccurrence of these asthma events, and in some cases, also reoccurrence of acute chest syndrome events in the same population of people with sickle cell disease. There is also an important aspect in the event that you do have these asthma-like symptoms and you have access to pulmonologists. This is one of the conditions where an MDT is very important, where you can work together with your pulmonologist to guide you, especially on interventions. And has been described by Dr. Joanita, the role of spirometry to be able to depict the presence of asthma based on the response of the bronchodilators. Inhaled corticosteroids are also important for long-term care, and also use of other leukotriene inhibitors, which are very important in controlling your asthma-like symptoms. Then more importantly, as you manage these children who have asthma or recurrent acute chest syndrome, you actually need to have consultations with either your hematologist within your space, or you can actually consult your pulmonologist. Asthma and sickle cell disease actually are associated with increased hospital admissions, and these increased hospital admissions can actually be reduced with the use of corticosteroids, as I had explained earlier. But more importantly is that you find that our exacerbations of asthma can lead to other complications as described. The pain events, the acute chest syndrome, and this can actually prolong your hospital stay if you are admitted due to such a condition. Close monitoring, looking at your vitals, such as your pulse, your SpO2, are very important for you to look at the response, and giving oxygen depending on your clinical assessment of this child or adult. Pulmonary function tests are very important, and this has been highlighted in the case that you actually need to have yearly pulmonary function tests as outpatients for those with sickle cell disease and those who may have had asthma-like conditions. And also it had been described that some of the long-term complications related to sickle cell disease, which are directly related to cardiovascular disorders, would require you to actually have an annual echocardiograph, because you're able to pick up some of the complications that are related to having both pulmonary and cardiovascular disease. So in conclusion, I have tried to describe to you that asthma is clearly associated with sickle cell disease complications such as acute chest syndrome. Acute asthma exacerbations in sickle cell disease need to be clearly identified and treated promptly to reduce mortality. Wheezing can be due to sickle cell disease as a condition, as I described, but also more importantly is your clinical evaluation to determine if this child actually has symptoms related to asthma, such as recurrent wheezing, history of specific triggers, or even nighttime coughs. Children with sickle cell disease require pulmonary function tests, and those who are at a higher risk also require echocardiography so that you're able to determine any pulmocardiovascular disorders which the child may have, so that you can prevent any worsening of these conditions as they move into adulthood. So those are some of my references that I used to prepare the slides, and thank you all for listening. I'll hand over to Professor Owusu to moderate on the Q&A. Thank you.
Thank you so much, Dr. Monube and Dr. Nampanja, for giving us this very insightful talks. We are so grateful, and I'm also very excited that we have such a huge audience listening to this very important topic. So we will go straight into the Q&A session. Please, you can unmute and then raise your hand. I will call you if you have a question. Alternatively, you can also put your question in the Q&A box, and then I will help to read it out. Whilst I'm looking, I know there was a question from Jean who said to Dr. Joanita, please, did you do repeat spirometry after starting formonide for the patient you presented? So, Doc, please, you can respond.
Thank you, Dr. Jean, for that question. We did not repeat the spirometry because currently we are weaning the child off. We're weaning her down. Come May, she'll be taken off the formonide. Yes. So for this season, we refused because of the weather. We didn't want to have a trigger for her. So we shall do it in May. That's the season for the review. Thank you.
Thank you. Okay, so great presentation in the chat box. What was the role of zinc sulfate in the management of this patient? This from Dr. Kenneth Okido. So maybe Dr. Monube can help answer that.
So thank you, Kenneth, for the question. So zinc sulfate has been associated with improved outcomes in children and adults with sickle cell disease. However, in Uganda, studies that have looked at specific supplementation of zinc in children and with sickle cell disease who present with painful crisis or who are hospitalized have not shown a significant difference. But the idea around here is that it's supposed to be a pro-inflammatory medicine, or should I say supplement, to reduce on inflammation, but it has not been well described within our setting. However, there are other studies in other countries that have shown the benefit that zinc would reduce inflammation. Thank you.
May I say something regarding zinc?
Please go ahead.
The patient is a multidisciplinary patient. So regarding the chest presentation, zinc has been studied to improve marked epithelialization in the airway following inflammation from pneumonia, acute chest presentations, as well as asthma. So in this regard, it was actually put in for the sake of the chest presentations. Thank you.
Thank you to both of you. We're still open to questions. Please feel free to unmute, raise your hand. I will call your name, then you can put through your question. I'm also busy looking through the chat box to see if there are any questions. So I will read it out. Great presentation, great presentation. Can you see? What was the rationale? Okay, so please, Joanita, there's another question from Jean again. So I think it's in two parts. Please let me try and read. Doing spirometry while on formonide would have been helpful to see how well controlled the patient was. I think it is useful to always do repeat spirometry for patients on inhaled corticosteroids. Also, as it also helps to know how controlled patient is and can even guide your weaning. What was the rationale for weaning this patient off the ICS? So maybe Joanita, you ask with that.
Just to clarify, the patient is not off her inhaled corticosteroid. She's still on low dose. She was initially on the moderate dose. Now she's on a low dose. We are weaning her down. I think I'm using the word wrongly. We are weaning her down the dose. We are supposed to repeat a spirometry in May for her review. She's current and comfortable with drugs. She really wants a drug holiday to really take her off for some time if she has a break, because she has this hydroxyurea, folic acid that she has to take every day. She actually told me if I don't take her off, then she will become an adherent. So I'm trying to negotiate with her so that we can have most likely a drug holiday, but not basically to take it off. The guidelines don't allow us to take it off. But for that purpose, we're trying to make sure we work with the patients. A bit of understanding. Yeah, but that is what I think the rationale should be. Thank you.
Thank you very much. So yeah, so patient is being stepped down on inhaled steroids. So yeah, okay. There's another question in the chat box. That's from Dr. Medeus. Okay. Does this management also apply to pregnant mothers? Thank you. So that's the question.
Thank you, Medius. I will have to put a disclaimer straight away. I don't treat pregnant mothers, so that is one key thing. And the management I described would actually be for non-pregnant people with sickle cell disease. Thank you.
Thank you, sir. Okay. So there's another question from Lillian Wambuzi. Hello. Why the CRP in this non-febrile patient? Okay, Joanita, you answered. Okay. So please, you want me to read it out? Since there's no hand that is raised. CRP is an acute inflammatory marker, and in presence of neutropenic sepsis will be a great indicator. Okay, so that's from Joanita. Esther Nakazi, this is tiny, but now directly be related to what has been presented. But I am interested in knowing from the doctors how useful and available inhalers are in medical facilities, as well. What are your thoughts on such patients being managed by primary healthcare workers, not specialists per se? Okay.
I will answer part of the question, and then I'll allow Dr. Monube to answer the other part. So the first part is about availability of inhalers. Yes, this year's motion is availability of inhaled corticosteroids in our facilities. These are actually very available. The only problem right now is probably affordability for some of the patients, but they are widely available and they come in all kinds of ranges, plus all other types of, apart from the inhaled corticosteroids. So this shouldn't be worried. I hand over to Dr. Monube to answer the other part.
Okay, so thank you, Dr. Nampija. For the availability of inhaled corticosteroids, this is something that is ongoing. Recently, the Ministry of Health has introduced what they call chronic care clinics, with the availability of training of healthcare workers to be able to manage patients with asthma and other non-communicable diseases. So I think this is ongoing. And also the level of the facility would be a key determinant on the availability of the inhalers. But from health center fours in our setting and above, inhalers should be readily available. Then I have another question with regard to the annual testing. Yes, so thank you, Jean. So this is one of our new protocols which we are implementing. As I mentioned, from the literature review, you find that outside of Uganda, and I would say outside of big centers, the incidence or should I say the prevalence of asthma were in double figures, between 15 to 20%. In Mulago, when a recent study was done, we were very surprised. We got less than 5%. It was actually about 4% of our children had asthma. But our plan is to have the mainly children from 6 to 7 years and above to have annual tests done within our new protocol. Thank you.
Thank you, sir. So I see Dr. Rebecca Nantanda's hand up. So please we'll allow Rebecca, and then I'll come back to the chat box. Please go ahead.
Thank you, Professor also, and the team for presenting. Rebecca Nantanda is my name, pediatrician and the Lung Institute in Makerere University. I just wanted to add to Esther Nakazi's question. She asked, what's the use of the inhalers? But she also had a question about primary care facilities, meaning generally health centers. So maybe to explain something, when somebody has asthma, it simply means that the tubes that take air in and out of the lungs become narrow and they're irritated. So for many years back, we used to use injections and also tablets, but the right way with advancement in medicine. We use medicine which is breathed right into those tubes where the problem is. The good news that we need a very tiny dose and with minimal, so that is the use of the inhalers, where those tubes have become narrow. We give you but in order to prevent those episodes from coming back again and again, we give you another type of inhaler, which you take every day, whether you are well or not, to prevent the attacks from coming back, but also to take away the symptoms that you may have. So that is the use of the inhalers. Now, the question of primary care facilities, it is possible to manage asthma in health center 3s and health center 4s because we have done research in this area. And once you train and mentor the people and you provide those inhalers, they are able to manage. But of course, we recommend that where there are complications, like in this case, if a child has sickle cell, anemia, and asthma, we would recommend that they refer them to the specialist for better, assessment and management and follow-up. Thank you.
Thank you, Doc. So I'll go back into the chat box. So, question from Jean again. Dr. Monube, is there a protocol in, I think it's Mulago National Referral Hospital for children with sickle cell anemia, where they are routinely sent for lung function tests annually? If so, which age group is this being recommended from? Okay.
So thank you, Professor Wusu. Just to re-answer, I had mentioned earlier that's from children above 5, 6 years. And this is a protocol which we are developing to be implemented within a short time. Thank you.
Thank you very much. Again, from Hilary, in a resource-constrained setting with no albuterol and hypertropium bromide, would nebulized salbutamol be of use?
I think the answer is yes. And important to note, our protocols, we actually start with nebulized salbutamol as our first line before we move on to other additional medicines. So I think yes, and also Dr. Joanita had actually responded to the question, and someone also helped us explain further that albuterol is basically similar to salbutamol. Thank you.
Thank you. Yeah, I see Dr. Joanita is busy on the chat box trying to answer some questions. That's good. Lots of thank yous, great presentation. So that's good work. Some adult patients refuse inhaled steroids despite understanding the systemic effects of tablets. How do we help them? It's fine.
So thank you. Maybe just from the aspect of many people, when they are diagnosed with asthma, they tend to want to shun the diagnosis, because many people think that they should be like a family history, or it is genetic, or it is some form of chronic disease. So if the physician or the healthcare worker doesn't sit down to counsel the patient, they actually may not believe that diagnosis, especially if it has occurred for the first time. So I think it's an issue of sharing more information and explaining why there is need to actually provide you with an inhaled medication. Thank you.
Thank you, sir. And I know Dr. Nantanda has done a lot of work around this. Rebecca, do you want to add anything?
Yeah, I had just responded in the chat. I think the person who asked about adults being hesitant to use inhalers, it's not only adults, it's really patients. What is important? It's not about telling the patient prevent a lot of, problems in the future. So communication at every visit is very important. Thank you.
Thank you very much. Okay, you responded to that. Great. So I think we've had a good discussion.
Prof, there was one other question that came up with regard to zinc. And like what I'd mentioned earlier, is that zinc supplementation in sickle cell disease in other countries had shown a significant reduction in what we call severe infections. When tested in our population, and it was actually a randomized controlled trial, there was no difference between those the assigned group and the non-assigned group. So that means those who were on placebo versus those who were on zinc, the number of infections was similar and there was no additional benefit. So it's still an open discussion. In the study that I'm talking about, they used 10 milligrams of zinc. Maybe the next study could look at increasing the dose based on prior understandings. But otherwise, the primary role of zinc when it comes to epithelialization, as mentioned by Dr. Nampija, is still key. Thank you.
Thank you very much. Okay, so I think we would like to wrap up because we are almost at the top of the hour. But you would all agree with me that we've had a very great discussion this afternoon. And I would like to summarize. Dr. Nampija took us through a patient, an adolescent she had seen in the clinic, who required admission, treated for acute chest syndrome, but still remained symptomatic with cough, breathlessness, and later required spirometry, which showed post-bronchodilator reversibility consistent with asthma and therefore needed to be initiated on inhaled corticosteroids. And subsequently, patient symptoms improved remarkably. Dr. Monube also took us through pathophysiology, trying to highlight inflammatory pathways, spoke about arginine, nitric oxide, and nitric oxide synthase, and what happens in both conditions as far as this process is concerned, because it's a very important inflammatory pathway in both conditions. Then he highlighted that studies from Europe and the Western world actually do highlight that there's small cases of asthma occurring in sickle cell disease. But again, he made reference to the recent paper by the group from the National Referral Hospital, which also looked at spirometry assessments in children and adolescents with sickle cell disease, and found that within the population at the National Referral Hospital, 4% of the patients had evidence post-bronchodilator reversibility consistent with asthma. So to sum it up, asthma, yes, it does occur in sickle cell disease, and so we need to screen for it. Actually, from the respiratory point of view, respiratory disease is common in sickle cell disease and is heterogeneous. So it may range from asthma to small lung volumes and to pulmonary hypertension to sleep disordered breathing. So it's quite a range. But I think I want to add my voice to the team to say that please, whether in primary care, whether in secondary level care or in tertiary care, please do ask about respiratory symptoms. Don't ignore cough, don't ignore episodes of difficulty breathing when your patients present to it. And I'm equally excited about the protocol that is being developed, looking at options of offering spirometry, for instance, to patients with sickle cell at the National Referral Center. I think we are also looking in in that direction. This is a very important group for us in Africa. Sickle cell is everywhere in Africa, and it's so important that all of us caring for patients with sickle cell need to understand that respiratory disease is really, really important to screen for, as daily questions about respiratory health when you see your patients in the hematology clinics, because they may have it, but they may not even know that it's important to report. So overall, I think my take-home message is asthma does occur in sickle cell disease. If your patient has asthma and sickle cell disease, both conditions need to be managed separately. You need to give inhaled corticosteroids per your national guidelines for managing the asthma aspect, plus manage the sickle cell per the national guidelines. Thank you so much for joining. At one point, we had 263 participants online. That's a very big number. And so I think this has been a great, great talk. Thank you, Dr. Nantanda, for inviting me to moderate this session. I'm so happy. I've flown into Makerere today, and I'm so happy. Today I get to be called a Ugandan. I'm so proud. And very soon, I'm sure I'll be there physically to pay a visit to all of you. Thank you for having me. My name again is Sandra Kwati-Newusu. I work at the Kofa-Nochi Teaching Hospital and the Kwame Nkrumah University of Science and Technology in Kumasi. Thank you and goodbye to everyone. Thank you to the technical team, Damali and Zara, who also helped in the background to put this great presentation together. Bye and have a great
Professor also. Thank you all.
Thank you. Thank you.
Bye.
Thank you. Thank you. Bye.
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 Bye. Thank you.
Thank you.
Bye. Thank you.